So today's Department of Psychiatry's ground rounds is going to be on opportunities to promote diversity, equity, and inclusion at UNM School of Medicine. So we got a great team of presenters, and I'm going to be introducing each one of them. First, we have John Paul Sánchez, aka JP, and he has worked extensively in promoting diversity and inclusion in the medical and academic medicine workforces. He is a co-founder and president of BNGAP Inc., which is it includes 60 academic health centers, and its goals are to educate trainees, faculty, and senior administrators on how to develop an upstream pipeline of diverse medical trainees to become future faculty and senior academic leaders. He is also the executive director of the Latino Medical Student Association, which is the largest Latino medical student association in the country. At UNM, he is executive associate vice president for DEI. He's published extensively, 57 peer-reviewed publications, and he is editor of the book Succeeding in Academic Medicine, a Roadmap for Diverse Medical Students and Residents. And his new coming book is The Health Professions and Academia, a guide to healthcare leadership careers that aims to inspire college and post-bacc to become faculty, seniors, administrators of health-related graduate schools. Dr. Sanchez obtained his medical degree from Albert Einstein and residency at Montefiore in emergency medicine. He also has an MPH from Yale. He identifies himself as having Puerto Rican ancestry. He identified, and he was raised in the Bronx. Now I'm going to introduce Dr. Smart. So Dr. Smart is Associate Vice Chancellor, and I'm not promoting you this time, Dr. Smart. I think I did last time I introduced you as Vice Chancellor. She's Associate Vice Chancellor for Leadership and Faculty Equity and Inclusion at HSC. And she has worked in the promotion of diversity among faculty, learners, and staff within the UNM Health Science Centers. She's also an associate professor in our department, and she is the training director of the clinical psychology internship here at the UNM Department of Psychiatry. Our third speaker will be Dr. Veronica Plaza, and she is the director in the Office for Diversity, Equity, and Inclusion at UNM School of Medicine, and also an assistant professor in the Department of Family and Community Medicine and in the College of Population Health. Interestingly, she's also faculty at the Spanish department at the UNM College of Arts and Sciences. She developed and coordinated the minor and major in medical Spanish for pre-health students. She is leading language equity initiatives focusing on medical Spanish education, assessment, and certification for faculty, students, and staff within the Office of DEI at the School of Medicine. So it is my honor to present this distinguished panel of speakers, and we will start with JP. Dr. Sanchez, please.
Well, buenos tardes. Thank you so much, Dr. Towen, for your leadership in your department, but also in serving as on multiple searches related to DEI. And it's always a pleasure to be able to co-present with Dr. Smart, who has been leading DEI efforts across HSC and assumed the responsibility specifically within your department and has served as a great colleague for the other DEI vice chairs and directors across the School of Medicine. And I'm happy that we're also have this opportunity to co-present with Dr. Plaza, who is the new addition to Office of DI within the School of Medicine. Next slide. So in terms of the learning objectives, we have 3 primary learning objectives. To quickly review some of the achievements that we've been able to bring forth with your support and the support of the other departments and units, with some new resources that have emerged from the AAMC, the Association of American Medical Colleges, and the ACGME, the accrediting body for GME for residencies and fellowships, and then share some really exciting new language equity initiatives. Next slide. In terms of the specific mission, vision, and values of the School of Medicine Office for DI, we don't have a separate set. We align and have adopted the mission, vision, and values of our HSC, our Health Sciences Center. So we've called upon our departments and our units within the School of Medicine to consider that. As you know, our mission is to serve the populations in New Mexico who are unique, who have many assets, but we've come to learn of their many negative health indicators. And we strive to address those negative health indicators to achieve health equity. Part of our vision is to create a diverse workforce. And I think we're uniquely able to do that with so many incredible graduate and certificate programs. And then in terms of value, I think it's really creating an environment, culture, and climate that recognizes, cultivates, and promotes all forms of diversity within our School of Medicine, but across the Health Sciences Center. Next slide. We should always be mindful of those accreditation standards that keep our programs accredited and facilitate this experience to be learners, faculty, and staff. I'd just like to highlight the main DEI accreditation standard of the Liaison Committee on Medical Education that accredits our School of Medicine. And you can see here that it explicitly states, the accrediting body states that we must engage in ongoing, systematic, and focused recruitment and retention activities to achieve mission-appropriate diversity outcomes, not only of our learners, but of our faculty, our senior administrators, our staff, and all relevant members of our academic community. And ACGME came out with a very similar accreditation standard that residency and fellowship programs have to show that they're meeting. But I think one of the most important things that ACGME said is they're not asking residency and fellowship programs to reinvent the wheel. We know that residency and fellowship programs are closely tied to our schools of medicine, and hence there should be close coordination with the efforts by the medical school, right? And that makes perfect sense. So we don't have to reinvent the wheel. We should be collaborating. Next slide. Just to once again highlight what we put forward in our LCME accreditation report is that as a School of Medicine, we are going to assume responsibility. We're going to work collaboratively to ensure that women and underrepresented groups in medicine of New Mexico, specifically Hispanic, American Indian, Alaska Native, African American, and Vietnamese, will be represented, not only represented, but we're going to work to ensure their full inclusion, promotion, and success. And that's because those groups are well represented within New Mexico, however, have faced unique challenges. In addition, we're going to focus on individuals of rural background with educational initiatives, in particular counties, and those individuals who are economically disadvantaged. When we think about our School of Medicine, it's not only those students pursuing MD degrees, but also our health professions programs, which, in the prior 2 medical schools I've been a part of, I didn't have access, right, to those students. And think about how lucky we are to be able to serve PA students, PT, OT, radiologic sciences. Next slide. So very quickly, and these slides will be provided, the School of Medicine Office for DI is responsible for crafting and implementing and evaluating overarching DI strategic plan for all those learners, faculty, and staff mentioned, meeting accreditation standards and helping our departments and units meet accreditation standards. Next slide. leading the development or subsequent editing of the mission, vision, and statements we submit to LCME or ACGME, as I've already shared with you, aligning and coordinating DEI related efforts between the School of Medicine, but also internal and external entities like the AAMC, ACGME, as well as community-based organizations in Albuquerque and across the state, and diversity-related national organizations like the Latino Medical Student Association and the Student National Medical Association. And many of you helped to bring the first SNMA regional conference to our institution this past October. Co-lead or co-advise recruitment, selection, matriculation, hiring, retention, success and promotion plans. And I've been really grateful how more and more departments and units are adopting holistic review, not only when we consider our graduate students, but also applying holistic review for hiring staff and senior leaders. And I'm grateful that even in identifying the new dean of the School of Medicine, holistic review is applied. Co-lead and advise School of Medicine DEI related feedback and research endeavors, community engagement endeavors. Next slide. Advise DEI related clinical endeavors, support a more positive and inclusive culture and climate, work with the Office of Professional Wellbeing around wellness endeavors, visibility for the School of Medicine. And as we do this, making sure that we track metrics and outcomes. So as you can see here from the scope, really similar to the other units, we are responsible for all 5 pillars, mission areas of the School of Medicine: education, research, clinical, community engagement, and diversity and inclusion. But not only are we of value in terms of supporting DEI, but because of the leadership of Dr. Saidonis, there's an expectation to achieve DEI-related outcomes and metrics for all of us, the students, the residents, the fellows, the faculty, the staff, the chairs, and the senior leadership. And I think that is a new change in our culture and climate that's really going to help us reach health equity or advance health equity. Next slide. So as you know, we've, over the past 2 years, and I'm highlighting the past 2 years because I started about 1.5 years ago, we've faced unique challenges. We have become more aware and more woken to, ongoing systematic racism and ethno-racism that is driving a lot of health inequity in many factors. COVID-19, we all are aware of the significant isolation, death, and loss that our communities and many of us have faced because of the COVID-19 pandemic. And then transition, we've seen a lot of great transition within the institution, but also that change and at times instability has been stressful and has led to fatigue, burnout, anxiety, and even depression for many of our community members. And I'm happy that the Department of Psychiatry and Behavioral Health has been able to step forward and support our learners, faculty, and staff during these 2 past years. Next slide. But as I say that, I also want to acknowledge that we really came together and galvanized to really address a lot of structural issues with the Office of DEI. And starting with Dean McGrew, our past dean, and being carried forward by Dean Richards, we have been able to evolve a more unified medical school infrastructure. We've been able to advance the budget within the Office for DEI and the staffing. And as you know, we recently hired Dr. Plaza, who will be introducing herself. Dr. Reyes is the new Assistant Dean of DEI. We're currently searching for an Executive Diversity Officer, and we've been able to hire Dr. Goodkind, as well as Dr. Salas to help evolve DEI curricula in UME and GME. There's been great support from the other medical school offices, with GME having their own diversity committee and Dr. Akshay Sood doing a lot around faculty affairs with Dr. Smart. Academic departments, the chairs have been great in stepping forward and identifying DEI directors and vice chairs and helping those DEI directors and vice chairs address minority taxation and structural barriers by making sure that they have SMART goals, assigned FTE, and their own budgets. So, I don't take those things for granted. It took a lot of work. And once again, it helps our directors and vice chairs move from a sentiment of minority taxation to really contributing to diversity capital. We continue to build strong relationships with our diversity-related organizations. As mentioned, SNMA holding their regional medical education conference for the first time this past October, and all the departments stepped in and supported that. And aligning closely with our HSC Office for DEI that brings us together with the other units. Next slide. This is the current structure within the School of Medicine Office for DEI. And as you can see, we have a great community, a great support system to do this work. I already highlighted the two new hires, some hires recently with the co-directors for DEI curricula, Dr. Goodkind and Dr. Salas, the vice chairs and directors across the 20 departments, as well as all the affinity groups that exist and have existed for decades. And Mike Kendall, who serves as the executive administrator. Next slide. And here, are the faces and the titles. These are, and I'm grateful, the individuals that not only step forward, but that departments are supporting as leaders, right, for DEI across our 20 departments. And, they attend monthly meetings, they've been working on strategic planning, and are really serving as the face of DEI, along with others for the School of Medicine. Next slide. As mentioned, we've been able to move to ensure that these individuals have assigned FTE on their annual promotion or their annual evaluation form. And I'm also grateful that the chairs have been working to include DEI metrics on every faculty member's annual performance evaluation, talking to the directors and vice chairs about them having a budget, and being clear about specific, measurable, achievable, relevant, and timely objectives for them to achieve for their own professional development or for the department. Next slide. And this is just an example of how different departments are assessing DEI accomplishments amongst their faculty. And you could see that different departments, some departments use a quantitative scale, some use qualitative measures, and some use both. But for me, this is critical. As we talk about a community who has felt undervalued, invisible, finally, we're coming together and saying, no, not only do we see your work, not only do we appreciate your work, but we're going to value it through promotion, through assigned FTE, through budgets, right? And we got to continue this trend. And if we continue this trend, we'll uniquely lead in a way that many other medical schools are not. So once again, I think this is something that everyone has contributed to. If there's any challenges to what you put on your annual faculty evaluation form, you're in excellent hands with Dr. Smart and Dr. Towen, but always feel free to reach out to me as well. Next slide. ACGME has incredible resources, Equity Matters. And I want to stop here because Dr. Smart, did I just go into your slides? Just stop me because I get excited and energized and I need to control myself. So
good, you got like 6 more, you're good.
Okay, I'm racing through. So there's a lot of great materials put out by different organizations. ACGME has created a whole host of teaching materials and videos specifically for residency and fellowship programs. Next slide. It's just a snapshot of the videos, as well as the AAMC has put out a groundbreaking report. And I know Dr. Smart is going to comment on this. It's titled the AAMC DEI Competencies and Milestones. Now, ACGME at this moment is not coming out with their own competencies and milestones around where we expect our learners, our medical students, our residents, our fellows, and our faculty to be related to a variety of topics. So really, this has become the gold standard in which we should be anchoring our curriculum and teaching materials. These competencies evolves with the input of hundreds of leaders across this country. So I would advocate for all of us to use it. And it's a great way for us to track our efforts on the departmental level across the School of Medicine, but also when you have to generate reports back to your accreditation bodies. Next slide. So just once again, to remind you, a competence is an observable ability of a health professional, resident, a fellow, or doctoral student in integrating multiple components such as knowledge, skills, values, and attitudes to do right, to provide equitable care to our patients. Next slide. And a milestone is a meaningful narrative describing the progress of our learners, residents, and faculty in achieving this competence. And as you can see here, and as Dr. Smart will go through with you, you don't have to do all of them at one time. You could pick and choose that which is most meaningful for your department. But more importantly, you'll notice that there's a column for a different type of learner. Although column 1 is supposed to be for medical student, column 2 is for resident and fellows, and column 3 is for faculty, the reality is that this was just released. And I would argue that all of us are starting in column 1. The expectation should not be that our faculty and our staff already have excelled and achieved the first 2 columns, because this is a new set of competencies milestones, and therefore there's not a lot of publications that we can rely on. Next slide. The design, you could read more about it, but I think what they really want to emphasize is that to meet these competencies and milestones requires critical reflection, formative performance assessment, and cross-continuum collaboration. And it's going to be really critical to do that if we're all going to be able to achieve these competencies and milestones. Next slide. So I think this is just, am I still good, Dr. Smart, or is this, yes? So this is just a better appreciation of one of the domains around equity. And as you can see here, after consensus, they found that mitigating stigma, implicit and explicit biases is a major competence for all of us to achieve. You'll notice that they decided that for our medical students, before entering residency, it's important, for example, for them to be able to articulate how one's own identities, power, and privilege influence interactions with patients. Spot on, at least through my biased eyes. For residents, seeking and acting upon feedback regarding how one's own identities influence patient care. And then for faculty, role modeling and teaching how to engage in reflective practices related to individual identities and powers. And this should not be so prescriptive that you only achieve this at the faculty level. I think our medical students in many ways are more advanced for a number of reasons and may be able to role model this for us in many occasions and for their peers. So this, they've laid it out in a nice table, but I think there's also flexibility. Next slide. So I think in terms, just in summary, how to use this, anchor your teaching and assessment activities to this document, take a moment to identify which domains and themes are most relevant to your learners, faculty, and staff, consider for who, and summarize. And the Office for DEI School of Medicine is going to work with you to help you summarize this on the departmental level for your accreditation standards, but also to summarize it for the benefit of the School of Medicine when we reapply for ACCREDITATION. And this summation can come through a dashboard, which Dr. Smart has been doing around faculty diversity. Next slide.
All right, this is me.
There you go. Thank you.
It's a nice segue for us to talk a little bit more directly about the Department of Psychiatry's and Behavioral Sciences DEI curriculum that we are working on with the current residency group. And before I show you a little bit of data and talk a little bit about the process and how this connects to what Dr. Sanchez just went over, is the goal of this is to think of how this curriculum can help the department continue to meet the accreditation and competency needs for DEI. But I think it's also important to consider each seminar, each didactic, each opportunity that our residents and interns and other learners in the department encounter, that these competencies should be woven throughout all of our trainings, not just those curriculums that might be very specific to diversity, equity, and inclusion. So one of the goals through this year was a perhaps innovative approach to thinking about how to create a curriculum that would be relevant for the current group of learners coming through in psychiatry. And so it's been a process of starting in the fall and moving through to the spring of meeting with each residency class in a didactic slot to co-create this curriculum. So rather than assume in my role as DEI that I know what topics would be relevant, I am not a psychiatrist. I didn't go through medical school and I didn't go through training here in New Mexico. And what we hope to do was align the knowledge of our current residents with what they feel they need with regards to this specific topic, and then crosswalk that with things that would be relevant for faculty training needs to be able to deliver the curriculum, and also how it matches with the competencies related to diversity and equity. The format of this curriculum is really meant to be one that touches on each of those columns within the competencies, the element of self-reflection, the capacity to gain knowledge and share knowledge, and the ability to role model, both as colleagues and peers and supervisors, the discussions and conversations and delivery of knowledge that we have built into this curriculum. And the goal is also to focus on a few specific areas that were also touched on in the equity competency grid, paying attention to elements of bias, elements of power and hierarchy, and gaining feedback in a very iterative way throughout the development of the curriculum so that it continues to expand. So one of the first areas that we looked at was what are the gaps and priorities for the residents. And then the next pieces will be then to map on resources for that, which may come from all of you on this call today to be participants in delivering the curriculum, or it may come from other departments. I think there's a couple folks from other departments on today, or we may need to continue to utilize community to provide the curriculum as well. The other piece is to then look at how to evaluate the competencies and what that would mean for a DEI specific curriculum, and how that could filter into the clinical settings as well. One of the big pieces that I am hoping with this curriculum development is that it does very much tie and map onto where residents might be clinically at any given time. So topics might be relevant for the first year in the clinics they might be, whether that's PES or ASAP or the VA or other clinics within the hospital. So that helps with the throughput of learning. It helps for opportunities to evaluate competency in a practice-based way, and really helps to bring the learning to life for both those residents and the faculty who would be interacting with those residents to see how the DEI is very relevant to their training as psychiatrists to be. So what I'm going to do is I'm going to show you a smart sheet that tells you a little bit about where we are at with this curriculum and the way that we are creating it. So there have been a series of Google Docs and smart sheet surveys at different points throughout the last about 9 months to gather input from each cohort year about those themes and topics that cross-cut the residency that would be important to incorporate. And what we are now at, we've gotten to the point where we've landed on a few themes, and we are looking at how does this curriculum look like it's going to be developed. And so I'll touch on that after I briefly go through this. There will likely be another time throughout our Grand Round series next year where I and a group of residents who have been being heavily involved in the creation of this curriculum will give a larger presentation on the curriculum as a whole. So what we have theme-wise that will cross-cut some of these areas of bias, diversity, and hierarchy and privilege are the history of psychiatry and human rights, cultural humility, topics that would be very specific to New Mexico, the element of cultural empathy, how to look at DEI and its intersection with the criminalization and the legal system, elements of gender affirming care, the intersection of diversity and wellness, consideration of socioeconomics, how to do DEI and not just talk about it, and looking at hierarchical structures in medicine, the overlap of DEI and psychosis and things that are important to consider, disability, resiliency in our patient populations with regards to diversity, equity, inclusion, bias, microaggressions, and body neutrality and body positivity, along with the cultural introductions, which Dr. Kanaka already provides for the psychiatry residents and incorporating that in different parts. And so the rest of this dashboard has additional data that we'll keep adding to about where some of these themes might land within a curriculum. And we, of course, will continue to evaluate what makes sense each year. So it's a living curriculum. One of the key aspects of thinking about this was the element of self-reflection that we were hoping to build in. And one of the ways that we are looking to do that is to consider the elements of asynchronous learning, an opportunity during a didactic hour where individuals are actively engaged in some sort of reading or TED Talk or podcast on a very specific topic, coming back together and engaging in dialogue and discussion, perhaps peer-led dialogues with faculty facilitation, allowing that opportunity for our faculty to role model these skills of self-reflection and growth as they go through the same curriculum in teaching. So that's just a very quick snapshot of where we are at with how we can link a DEI curriculum for our department and how it relates to these competencies and elements that Dr. Sanchez mentioned. So the next piece that we're going to switch over to now is leading us into this element of language, which will take us to ultimately Dr. Plaza to give us some information around medical Spanish initiatives. One of the things that I most want to highlight is resources, of course. Here's a resource that you can, if you just Google a guide to language, narrative, and concepts, it'll pop right up. But you will also have access to these slides to be able to go to this to review, is to consider how we use language in our spaces. And a lot of times dialogue doesn't happen because people are uncomfortable with language or using the wrong terms. And one of the things that this guide can helpfully do is understand some basic glossary of information, why the language we use is important, some ways to think differently about it, and also to anchor our language into equity, that the way that we talk about things really should help us focus on the systems and the structures that are perhaps not working as well as they are, and not so much on the individual person, and which leads to feelings of blame on individuals specifically. So hopefully you can find this guide to be useful, and we'll touch on little pieces of it right now, and then that'll give you a little bit of a teaser to go back and review it in more depth. It's not too long, it's only 50 pages. I'm sure you could fly right through it. Within that, and we're going to go through each of these, so you don't need to read through these now, are nice grids which help you understand what the principle is, what terms you might use. And I myself, when I was looking through this, was thinking that there are lots of times when I have not used person first language, and giving you alternatives, strategies to not just use, but to think about what does it mean by using that term instead of this term. So what is important to switch our narrative from individualistic to more of an equity lens? And you know, when I think of this more specifically, I do really feel like it helps us to be a little bit more solution focused and directive in thinking about problems. When we can focus more on the equity component, the capacity to think about what are the things that are happening that lead to individuals perhaps having had labels in the past. It's not through the fault of the individual all the time, or most of the time. It's the systems and the structures that have perpetuated throughout time to continue to contribute to those elements of inequity. So what I hope through just reading through that resource is it gives folks an opportunity to land in a equity-focused person-first language to help center the lives of people and communities without reinforcing labels, which continues stigmatization and marginalization. So what are a few examples? So you can have some here. This term is used quite a lot, which is the aspect of vulnerable and marginalized and high risk. And an alternative way of focusing this in equity would to be focused on groups that have been historically, economically, socially marginalized, communities that have been underserved because of lack of resources, groups that are struggling against marginalization as a result of, and then you can fill in the gaps. Avoiding dehumanizing language. This comes up sometimes in our quest to be efficient. And I think that the goal sometimes of recentering on equity focused language does mean to slow down a little bit in our communication and to pause before we say things. So rather than thinking of somebody who is obese or morbidly obese, thinking of people with obesity or people with severe obesity, the homeless individuals who may have lack of housing, lack of access to housing. And so really, again, focusing on the circumstances rather than the person. Remembering that there are lots of subpopulations, and sometimes we utilize catch-all terms in efforts, again, to be efficient, or just because that's the way that our language has developed within our own fields. And so being as specific as possible really does help to be direct in what is needed for a specific group of individuals, and also helps individuals to really be seen and heard and included in a way that large terms may not allow. Trying to avoid combative, aggressive terms when we think of working with diverse communities. So instead of thinking about targeting communities, targeting and aiming and things that create this visual of conflict with individuals from diverse groups, thinking about opportunities, being able to engage, prioritize our efforts, focus on an intended audience, are less aggressive ways of referring to work that we might do with individuals from diverse groups. Avoiding unintentional blaming, focusing on the fact that sometimes individuals are not at fault for things that are related to limited resources, that the systems themselves are the ones that are at fault. So with that, I'm going to transition to another element of language for us to consider. This one I know is relevant for thinking about our residents who, during the course of our DEI curriculum building, it has come up a few times about why it would be important for us to have a requirement for a medical Spanish for our psychiatry residents. So I look forward to learning more from Dr. Plaza.
Thank you so much. So part of, continuing with the importance of communication, clinical communication, is to also have an understanding of who are we serving. And with that is like, who is the population in our state? And so the next slide, well, when we look at who we serve, and look at New Mexico, we are a minority majority state, meaning that 49% of our population are identified as Latino, Hispanic, or Spanish origin, and another 11% are identified as Native American. And among those two groups, be bilingual is part of the identity, as part of that, who we are. And so, we have the data in terms of like, that key component of language is not only something that happened at home, but it's only that is a way that how we operate in our society. And we have, the research have shown that bilingualism can help, to develop the development in terms of brain executive functions. But it's also not only part of who are the people that we serve. There is also regulations that preserve preserve the language and the rights of our population to receive education and training in their preferred or native language. And those are like what we call the New Mexico Native American Education Act and the New Mexico Hispanic Education Act. That is not only focused on K-12, it's also focused on higher education. And so as part of that and part of the being a higher education institution, we are under what is the definition that is called a Hispanic serving institution. That definition is a federal definition or for higher education institutions that serve at least more than 25% of their population is of a Hispanic origin. For UNM, we are 49% of our undergrad population is Hispanic. So in terms of, when we look at the report for the Hispanic Education Act or the Native American Education Act, as an institution, we have to report where efforts and initiatives that we do in order to accommodate these learners. And so that's kind of an overall. But when we look into health, if we move into the next slide, there is also national standards that they are from the U.S. Health and Human Service Department and from the Office of Minority Health. They are called CLAS, and that start from Cultural Linguistic Appropriate Services. And those are the standards that they're part of our accreditation as a healthcare organization, our JCO. The Joint Commission look into on how we provide cultural linguistic appropriate services to our population. In order to accomplish some of those, our university health science have a language services and provide language interpretation. And that has been over the years has been expanded. Still, we're not meeting the need. And we know that the quality sometimes, and if interpreters are not used, the quality of care and the health outcomes of those clinical encounters get compromised. So part of that, process on improving on how we meet the class standards is kind of providing ongoing training for our learners, faculty and staff. And that's another requirement that are part of those class standards. What we have done over over the years also is in alignment with at the national level with the efforts to doing some standardization of those education initiatives among all the medical school. We'll have the honor to have Dr. Pilar Ortega to be presented next Tuesday, as part of the Women's History Month, and on Tuesday at 12. So if you can join, she will be touching on those efforts at nationwide in terms of like standardization of the medical Spanish education in the U.S. medical schools. There is also a great group of growing literature in terms of medical education. So we encourage you to use a med portal to look for some of those educational instruments. And there's also part of, our own efforts. And so as part of our own effort, we have done different, historically, we have been working in the School of Medicine in develop pilots and develop electives that for our learners on how to, for example, work with the medical interpreters and also how to, enhance your language capacity with, in medical Spanish. During the pandemic, we were partnered with Canopy to do, and we did a health science wide online program and provided us as without any cost. So we'll share more about those results later. So that helped us to kind of identify that our community has high interest on continue develop their language skills and develop, clinical communication skills in Spanish. Next slide. So as part of the work that we've been doing, we're gonna as we develop or enhance our work, one of the goals will be to certify those providers and learners that are bilingual, and so that we can have, a process that can be used to assess their competency, and then once they're being certified, they can provide care without any interpreter. That process we'll be working on identified as a portfolio of exams that are available nationwide, that you can access. We'll also be partnering with some of the other university, or collaborated with other universities nationwide, like the El Paso Techs, that they already have implemented a medical Spanish as part of the medical curriculum. Case Permanente, who for those providers that are being certified, they get a special pay for that, for having those skills. We're partnered with the University of Nacional Autónoma de Mexico, UNAM, and some schools in Puerto Rico to create opportunities to go and do some immersion programs or exchange programs. Next slide. So as we develop this, we're going to be using, in terms of the curriculum that will be developed, will be kind of similar to the existing medical school curriculum. We'll have a Spanish track, and we'll hope to develop that initially through doctoring, and then clinical reasoning, and developing using standardized patients and OSCEs, where the patients will be the standardized patients will be bilingual or Spanish speaking. So we'll kind of develop these competencies in a safe environment where will not be affecting patient safety or quality of care. And as part of that, we have also been in discussions to develop the visiting faculty medical competency fellowships. So those are all things that are in progress. Next slide. So part of that, that metric that we're going to be using in terms of to evaluate our work will be kind of in hope that we increase the proportion of staff, learners and faculty who will be certified. Then also will increase the number, right now in terms of metrics, we do not have a good baseline of faculty affairs or human resources are not collecting language capacity. So part of our process will be to develop an asset mapping where we can identify where is our asset and human capital in terms of language within our organization. At the same time, we want to frame in terms of patient safety and quality improvement, and also help us to monitor and use the same metrics that some of the accreditation organizations related to clinical communication skills. Next slide. So as part of those are like an overall goals, but are kind of in a more short term where we're looking to identify, and your department will probably already got the email with the survey. We're looking into identify language equity liaisons across the School of Medicine to be part of the language equity team. That will help to develop the asset mapping in terms of language capacity within our institution. And that part of that, when we have that, we'll be able to identify the first cohort of the School of Medicine members to be able to get them certified. And in the part of the language equity team also will be to review and enhance some of existing policies and procedures that can support language equity through the process in admission, hiring, retention, and promotion practice with the School of Medicine. So next slide. So what will be the roles of the language equity liaison? So probably will be the person will be as a point of contact within the department to disseminate and collect information, serve as an advocate for language equity within the 5 missions of our institution, as well as, addressing some equity concerns and participate on the large community. We'll have every other month meetings, and at the same time we'll help in the process of curriculum development, professional scholarship work, and hopefully will enhance, can help to enhance some of the recruitment, retention, and promotion strategies. So I would like to encourage you to, if you're interested, to work with your chair to be able to serve as a language equity liaison to your department. That will help us also to tailor the concerns based on the department needs. Next slide. And I think this is
this brings us to the end for today. And before we open it up for questions, an opportunity to leave you with some reflection questions. We don't need to answer these right now, but to think about how we and you and our department can lead in DEI excellence. And sometimes by just reflecting on these stems, it gives you a little bit of guidance. How has our department supported diversity, equity, inclusion? How have you been able to support it? And how and why are our department, medical school, state of New Mexico diverse and inclusive? So you can add that to your reflective activity for today. And with that, I will open it up for questions. I'm going to stop sharing. You can see people's faces. Any questions folks have or comments?
I'm one of the residents who's been kind of adding a voice to some of this, and thank you so much for this presentation and for showing kind of where we're at in the process. It's really exciting to see it all laid out like this, so I appreciate your work. Thank you.
Thank you, Dr. Wick. A group of the residents also were able to see one of our most recent TED Talks on how to have difficult conversations. And one of the tenets, if you remember it, is to be okay with silence, because the space will get filled with important information. So, but I'll also let Dr. Towen decide when he when he would like to end the call.
Well, we like to stop 5 minutes before the hour, and that is now. So thank you to our panel of speakers. It was very informative and actually very rewarding to see the great work that we've done in our department, thanks to your leadership, Dr. Smart, and of course with the support of other leaders at UNM, such as Dr. Sanchez and Dr. Veronica. So thank you again, and folks, have a good weekend and stay healthy. So long.